Welcome to the deep dive. Today, we're tackling a really critical and complex issue, substance use.
Right. And how we as a society are trying to address it.
Exactly. We're going to be sifting through a collection of really informative stuff, scientific reviews, policy analyses on harm reduction, even insights from places like the Mayo Clinic.
And the National Institute on Drug Abuse
Yeah.
and idea, yeah, looking at the nature of addiction itself.
Our mission, especially for you, the learner, is to pull out the key insights. We want to give you a clear, structured picture of this whole thing.
Yeah, the different ways we're thinking about it, the evidence, all without getting too bogged down.
Trying to find those aha moments, connecting the dots.
Okay, so we've got a scoping review, is that right? From the Journal of Substance Use and Addiction Treatment.
Yep, it digs into how things like poverty, education, community, how those social factors impact substance use disorders over a whole lifetime.
That's the social determinants of health piece. Very important.
And then there's this analysis from the Cicero Institute. Quite thought-provoking. It looks squarely at the public health consequences and really examines the evidence for different harm reduction strategies.
Right, and we'll fold in those perspectives from Mayo and NIDA too, just to ground our understanding of addiction.
Now, it's important to say some of this stuff, it can get politically sensitive.
Definitely.
Our goal here is just to report impartially on what's in these sources, present the different perspectives without taking sides.
We're here to understand what the sources are actually telling us, not push an agenda.
Okay, let's unpack this then. And just to start, get this. Did you know that in the U.S., deaths from drug overdoses more than doubled between 2015 and 2021?
It's a shocking statistic.
This part. For young people, ages 10 to 19, fentanyl was involved in 84% of those deaths. 84%.
Wow. That really highlights the urgency, doesn't it? And how much the landscape has shifted, especially for younger people.
It totally underscores the stakes here.
And that Cicero Institute data really drives home the scale of the crisis.
Yeah.
You said over 100,000 overdose deaths in 2021.
Yeah, a 92.3% increase since just 2015. It's dramatic.
And like you said, the surge among young people is deeply concerning. But it's not just overdoses, is it?
No, the analysis points out the wider impact, too.
Right, how substance use gets tangled up with other big issues like crime. They estimate something like 85% of people in prison have addiction issues.
And homelessness, too. About 1 in 3 homeless individuals using methamphetamines, according to their sources.
It really paints a picture of this complex web of interconnected problems.
And that scoping review we mentioned, it really emphasizes looking beyond just the individual.
Exactly. Considering those social determinants of health, or SDOH,
Yeah.
these bigger environmental social conditions, they really matter for health outcomes.
Including substance use starting it, how it progresses, the risks.
Everything.
Okay, so these SDOH, the review looks at how they play out across someone's life.
Yeah, from maybe the first time someone experiments, all the way through to potential long-term issues, or even mortality.
And the studies they looked at followed the same people for a long time, right? Why is that important here?
Precisely. They looked at longitudinal studies. Following the same individuals lets researchers see how factors like poverty, education, housing, social support, how these things might contribute to, or maybe protect against, substance use as life unfolds.
Ah, okay, so you can see clearer connections over time.
Exactly. The review aimed to summarize all that,
Yeah.
narratively and even graphically.
Which kind of leads us into this whole idea of harm reduction. It's a different philosophy, isn't it?
It really is. A
Okay.
fundamental shift, you could say. Instead of just focusing purely on abstinence.
Getting people to stop completely.
Right. Harm reduction aims more at minimizing the negative consequences associated with drug use, meeting people where they are.
Offering support they're willing to accept, even if they're still using.
Yeah, like the example you mentioned, giving out clean needles to stop HIV or Hep C from spreading.
So it's pragmatic, trying to reduce the immediate risks.
Exactly. Providing practical care. That could be education on safer use, testing for diseases, handing out naloxone for overdoses.
But the Cicero analysis stresses that policymakers really need to look closely at the evidence for each specific practice, right? Not just accept the philosophy wholesale.
Absolutely. Weigh the evidence carefully. Because the health challenges are huge.
Both the direct effects of the drugs and the risky behaviors that can come with use.
Yes. And harm reduction tries to interrupt those risky behaviors to cut down on disease and death.
And the Cicero Institute points out that the risks aren't the same for every drug or every way of using it.
Definitely not. Injecting drugs, generally. Highest risk for diseases, opioids. Highest risk for fatal overdoses.
And that method, the route of administration, really matters for health risks, doesn't it? The analysis breaks down oral, injection, inhalation, intranasal.
It does. Taking drugs orally, like pills. It's common, especially illicit prescription opioids, but it has its own risks.
Like stress on the liver.
Yeah, exactly. Opiates are actually less potent orally because the liver filters some out first.
Oh, okay.
But that filtering process itself can strain the liver over time.
Then there's injection. The analysis mentioned, 3.6 million adults in the U.S. injecting drugs, heroin being common?
Right, and that route carries really serious disease risks.
HIV, hepatitis C.
Absolutely.
Yeah.
HIV, while mostly spread sexually now, still accounts for maybe 8% of new infections from injection use. But Hep C, that's way more common among people who inject. Rates can be incredibly high, like 70–90% in long-term users.
Wow. And it spreads fast among new users, too.
Alarmingly fast. Plus, skin infections are a big problem, about 10 times more likely if you inject.
Understanding these different risks really sets the stage for looking at harm reduction strategies, doesn't it?
It does, because many of these strategies are designed specifically to tackle these dangers we're talking about. Let's maybe dig into some of those practices.
Okay, what about inhalation? Smoking drugs. Seen as less risky than injecting, maybe, but still harmful.
Definitely not harmless. You're looking at damage to the respiratory system, higher risk of things like asthma, lung cancer, pneumonia.
And they mentioned severe dental problems with meth use, the whole meth mouth thing.
That's right. And interestingly, some studies found similarities in negative outcomes between people who smoke meth and those who inject it.
Huh. Though injecting fentanyl seems worse for overdose and skin infections than smoking it.
Correct. That distinction seems important.
And finally, intranasal use, snorting. Maybe less stigma, sometimes lower disease risk.
Potentially, but it still damages the nose badly. Can cause sores, even holes in the septum.
And with meth, they said the less intense high from snorting might lead to using more often.
Yeah, that's a potential downside. It's fascinating how the Cicero Institute really flags that drug use overall has just become so much more dangerous because of fentanyl.
Right, these potent synthetics. The example of methamphetamine overdose deaths jumping 180% between 2015 and 2019, while the number of users only went up 43%. That's stark.
It really is. And that other statistic you pulled out.
The 54% of meth-related deaths involving a mix with opioids.
Yeah. It just shows how unpredictable and contaminated the drug supply has become. It's not just one substance anymore.
No. And the analysis also brings up using alone as a risk factor. Many opioid deaths happening in private homes.
Right, where there's no one to help if something goes wrong.
So drilling down into causes of death, methamphetamine and opioids seem to be the main drivers, according to the sources.
They are. Meth users face a much higher risk of dying prematurely. The specific causes cited vary a bit between studies.
Suicide, accidents, cardiovascular issues, HIV, cancer, overdose.
Right, a whole range. But the overall picture is high mortality, and suicide attempts are unfortunately common.
And for opioid users, similar high risks.
Yes. Accidental overdose is a huge factor, obviously, but also cardiovascular disease, cancer, suicide. And Hep C complications are significant too.
Okay, so we've painted a pretty grim picture of the problem and the risks. Let's pivot towards solutions, or at least attempted solutions, harm reduction practices.
Right. And it's the broad category. The Cicero Institute lists things like information and education,
Counseling.
fentanyl test strips, naloxone distribution, Good Samaritan laws,
Overdose hotlines, needle exchanges.
medication-assisted treatment, or MMAT, and then the more controversial ones like supervised injection facilities.
And the analysis suggests the evidence for how well these work varies quite a bit.
It does.
Yeah.
Let's take information, education, counseling.
Yeah.
Seems basic, right?
Yeah, straightforward. What's the evidence?
Well, studies show they can increase drug literacy awareness. Some hints it might reduce the likelihood of teens starting drug use. But the Cicero Institute points out we need more research on long-term behavior change and which ways of delivering that info work best.
Okay. Fentanyl test strips. Getting a lot of buzz. Seems like a practical tool.
They are. They're generally accurate for fentanyl and its cousins. And studies show people do change behavior when they use them smaller doses, feeling safer.
But limitations exist. User error. Can't detect everything else that might be mixed in.
Exactly. Plus, there's still illegal drug paraphernalia in many places, which is a major barrier.
Naloxone, the overdose reverser, now available as Narcan nasal spray, much more accessible.
And it works. High survival rates when it's used. The Cicero Institute acknowledges that. Bystanders will use it if they have it and know how.
Okay, but didn't the analysis mention a study with some surprising negative findings?
Ah, yes. That's a key point they raise. One study suggested that wider naloxone access might, counterintuitively, lead to more opioid use and maybe even more crime, without actually reducing overall deaths.
Whoa, hang on. How could that happen? Making an antidote more available leads to more use.
The theory proposed in that study was a sort of safety net effect. If the immediate risk of fatal overdose feels lower because naloxone is around, it might inadvertently encourage riskier behavior or reduce the incentive to seek treatment for some.
That feels really counterintuitive. Is that widely accepted?
It's definitely not the consensus view, and it's just one study, highly debated. But the Cicero Institute includes it to show the complexity and the need to look at potential unintended consequences. And of course, naloxone only works for opioids.
Right, useless for a meth or cocaine overdose?
Yeah.
Okay, good Samaritan protections, laws, so people aren't afraid to call 911.
Yeah, the idea is to remove that fear of arrest. Evidence suggests they might increase calls for help and maybe reduce deaths, but the research is still pretty limited, and results seem to vary depending on the place.
Overdose hotlines. People call while using. An operator stands by.
That's the concept. The Cicero Institute says there's limited evidence they're effective right now.
But less controversial than supervised injection sites.
And legally simpler, yes.
Okay, needle and syringe exchange programs, NS-EAPS, these have been around a while. Goal is reducing HIV, Hep C.
Primarily. And getting dirty needles off the street, maybe connecting people to services.
So do they work for disease prevention?
The meta-analyses, those studies of studies, suggest they are effective in reducing risky injection behaviors linked to HIV.
Okay, that's positive.
But the evidence for reducing Hep C, which is actually more common among injectors, is weaker, less conclusive.
And didn't the Cicero analysis mention some concerns?
Yes, they highlighted one study specifically that found troubling links between NSEPs and increases in drug-related crime and overdose deaths in the areas around them. That raises serious questions for policymakers.
So not a universally positive picture there. What about getting needles off the street?
Some evidence suggests they do help with reducing public needle litter, but getting people connected to wider services beyond just swapping needles. Limited evidence that happens consistently.
It seems like even for established methods like NSEPs, the evidence is more nuanced than you might think.
Absolutely, especially when you look at different outcomes, HIV versus Hep C, public litter versus crime rates.
Okay, medication-assisted treatment,
Yep.
MESMEP. Using things like methadone or buprenorphine, this seems like a cornerstone of opioid treatment now.
It really is. And the evidence here is strong for reducing mortality risk significantly, up to 500% reduction in some studies.
Wow, 500%. That's huge.
It is. And it's linked to lower disease transmission risks, too.
But it's not a magic bullet, right? The analysis mentions ongoing illicit drug use is common even for people on MMET.
That's true. Compliance can be an issue, and sometimes people continue to use other substances. There's also diversion non-prescribed buprenorphine use, especially in places like jails.
And just getting a MAT can be hard.
Access is still a major challenge in many communities, yeah.
All right, finally, the really controversial one. Peer and supervised injection facilities, CEFs. Safe places to use drugs under watch.
Extremely controversial. Advocates always point out, no reported overdose deaths inside the facilities.
That seems like a clear positive.
It does, and a systematic review suggests they could reduce overdoses and deaths in the immediate vicinity. Maybe modest increases in people starting addiction treatment. Some evidence crime might decrease right around them.
Okay, sounds promising so far.
But the Cicero Institute perspective emphasizes major criticisms. Lack of really rigorous long-term studies. Concerns that very few people actually transition from using it, the CIF, to getting into formal treatment.
The enabling argument.
Exactly. Critics argue they normalize and enable drug use and potentially increase crime and disorder in the wider neighborhood, even if it's down right next to the site. And recent studies hint at possible gender differences in overdose rates inside CIFs, too.
So the evidence isn't consistently supportive.
Far from it. Even some people involved with CIFs express concerns about effectiveness and unintended consequences. It's really a focal point of debate.
Okay, so navigating all this. Harm reduction, treatment, prevention, it really helps to understand addiction itself. Let's touch on those insights from the Mayo Clinic and INERO.
Right. They frame addiction clearly as a disease. Affects the brain, affects behavior, leads to that compulsive use, even when things are clearly going wrong.
And it can start innocently enough. Experimental use, maybe even prescribed meds.
Absolutely. And the symptoms they list are important. Feeling you need the drug regularly, intense urges, needing more for the same effect tolerance.
Taking more than you meant to, spending money you don't have, neglecting work or family.
Continuing even when it's causing problems, doing unusual things to get drugs,
Yeah.
taking risks while high, spending tons of time getting, using, recovering.
Failed attempts to stop, withdrawal symptoms if you try. It's a whole pattern.
It really is. And recognizing it in family members. Mayo Clinic points to things like school or work problems, physical health declining, appearance neglected, secrecy, money issues.
And just being aware of signs of intoxication helps, though they vary so much by drug type.
Totally. Cannabis is different from depressants, which are different from stimulants, hallucinogens, inhalants. Each has its own profile.
And fundamentally, NIDS stresses these are lasting changes in the brain's circuitry. The reward system, self-control. It's not just about willpower.
No, it's a brain disease. And risk factors play a role. Family history, other mental health issues, peer pressure, lack of family support, starting young, the type of drug itself.
And prevention. Communication, listening, being a good role model, strong family bonds. Seems basic but crucial.
Definitely. And when treatment is needed, it should be comprehensive, address the whole person.
Medical, mental, social, job, family, legal needs. It's all connected.
Right, using medication, different kinds of therapy, CBT, motivational interviewing, family therapy, 12-step approaches, whatever fits the individual.
And understanding that relapse, it's often part of recovery. Not a failure, but definitely dangerous because tolerance can drop.
That's a critical point about safety after a period of abstinence.
Yeah.
And finally, they distinguish between dependence, tolerance, and withdrawal, which can happen even with prescribed meds and addiction, which is that bigger disorder with loss of control and negative consequences.
That's a really useful distinction. Dependence doesn't automatically equal addiction. Okay, the learner. Let's try to wrap some of this up. Key takeaways from this deep dive. We've covered a lot, the sheer scale of the substance use crisis, the role social factors play, and this really diverse, sometimes contentious world of harm reduction.
You should have a much clearer picture now of the different approaches, what they're trying to do, and crucially, the varying levels of evidence behind them. Sometimes strong, sometimes mixed, sometimes limited.
We've seen how drugs are used changes the risks, how the drug supply itself is more dangerous now, and just how complex addiction is as a condition.
And let's circle back to that really stark fact, the doubling of youth overdose deaths, 84% involving fentanyl, thinking about what we discussed, test strips, naloxone access, their potential and limitations. What stands out to you now as a possibly impactful area?
Yeah, it makes you think differently about the specific tools, doesn't it? We also tried hard to present the different viewpoints from our sources.
Right, the public health perspective alongside the analysis, raising concerns about some harm reduction methods. It highlights that this is an ongoing debate. Careful evaluation is essential.
And for you, wanting knowledge quickly but thoroughly, hopefully this gave you that solid foundation, multiple angles, maybe some aha moments without getting totally swamped.
We aimed for clarity across complex information.
So here's a final provocative thought for you to chew on. Considering everything, the social determinants, the changing drugs, the mixed evidence for interventions, what do you think is the most critical area for future research and policy? Where should the focus be?
Is it prevention? Is it better treatment access? Is it refining harm reduction? And within those, which specific strategies seem most promising or maybe carry the biggest hidden risks? Lots to think about.